Welcome to Accidents, Disaster, and Bioterrorism, which is week 14 of CPN 4. 141 million patients per year visit the emergency department, leading to overcrowding and long wait times. 11.2 million are admitted to the hospital, and the numbers are increasing not only due to COVID, but also their inability to see a healthcare provider, an aging population, shorter hospital stays resulting in frequent readmissions, acute mental health crises, emergency department and hospital closures, and a lack of or inadequate healthcare insurance or a healthcare provider. So we see lots of people who have life-threatening problems. They could also be potentially life-threatening or urgent problems that brings them to the emergency department. The Emergency Nurses Association, or ENA, is a specialty organization aimed at advancing emergency nursing practice. The ENA provides standards of care for nurses working in the emergency department and a certification process that allows nurses to become certified emergency nurses, or CENs. Recognition of life-threatening illness or injury is one of the most important goals of emergency nursing. Initiation of interventions to reverse or prevent a crisis is often a priority before a medical diagnosis is made. This process begins with your first contact with a patient, and prompt identification of patients requiring immediate treatment and determination of appropriate interventions are essential to nurse competencies of an ED nurse. In ED nursing, we learn to triage or to sort, and this is a process of rapidly determining patients' acuity and represents a critical assessment skill. The ED nurse most often confronts multiple patients who have a variety of problems. So the triage process works on the premise that patients who have a threat to life must be treated before any other patients. We categorize them to the most critical as treated first, and this ESI is called an Emergency Severity Index. We use, at St. Francis, we use the 5-tier that includes a triage algorithm to assign their ESI level. It incorporates concepts of illness severity and resources used to determine who should be treated first. So Table 68.2 will define this a little bit further. This is supported by ENA and the American College of Emergency Physicians. So what we're going to look at is the stability of vital functions, or their ABCs. An ESI 1 is unstable, an ESI 2 is threatened, an ESI 3, 4, and 5 are all stable, but we have to continually assess these patients because they can take a turn and easily go higher acuity. We're also going to look at the life threat or organ threat. If it's an ESI 1, it's obvious. 2 is likely but not always obvious. 3 is unlikely but possible. And 4 and 5 are no threat to life or organ. We want to ask, is this a high-risk patient who should not wait to be seen? Next, we're going to look to see how soon before they're treated. If it's an ESI 1, it's immediately. 2 is within 10 minutes. 3 up to an hour. 4 and 5 can both be delayed. Normal vital signs are required for patients assigned to an ESI level 3. Patients with abnormal vital signs may be reassigned to an ESI level 2. We're also going to look at the intensity or the expected resources that we're going to use for them. If it's an ESI 1, they're a high resource intensity, meaning they need lots of equipment, medications, etc., to be able to stabilize them. Staff is at the bedside continuously, and often we have to mobilize the team response, so a code blue. An ESI 2 is a high resource intensity. Multiple, often complex diagnostic studies are used, frequent consultation from other parts of the medical field, and continuous monitoring. An ESI 3 is immediate to high resource intensity. Multiple diagnoses, studies such as multiple labs, x-rays, brief observation, complex procedures such as IV fluid, bolusing, and drugs. ESI 4 is low resource intensity, one simple diagnostic study, for example, an X-ray or a simple procedure, which would be sutures. And then an ESI 5 is a low resource intensity and examination only. So examples of our ESI, if they're an ESI 1, that would be a cardiac arrest, intubated trauma patient, overdose with bradypnea, severe respiratory distress. ESI 2, chest pain, probably resulting from ischemia, multiple trauma, unless responsive. ESI 3 is abdominal pain or gynecological disorders, unless they are in severe distress, or hip fractures in an older patient. ESI 4 is a closed extremity trauma, simple lacerations or cystitis, and an ESI 5 is cold symptoms, minor burns, recheck wounds, prescription refills, things like that. After you complete the initial focused assessment to determine the presence of actual or potential threats to life, we're going to proceed with a more detailed assessment. A systematic approach to this assessment decreases the time needed to identify potential threats to life and limits the risk of overlooking a life-threatening condition. A primary and secondary survey is the approach that is used for all trauma patients. For non-trauma patients, the primary survey is followed by a focused assessment. So again, trauma patients get primary survey and secondary survey. Non-trauma patients, primary survey and focused assessment. We are going to use your alphabet, and we do have one more letter, and that is I. We consider the alphabet system to guide us through our assessment in an emergency situation. We also want to make sure that the scene is safe. That is pertinent every time we assess a patient, no matter if you're in a hospital or out in the field. We're going to check the level of consciousness, the work of breathing, their breath sounds. Do they have a kill or bleed? Is their skin color warm? Or what is their skin color, and what is the temperature? We need 2 large bore IVs. We're going to check cap refill frequently. We're going to check them neurologically for AVPU, and we'll talk about that in a little bit, and pupil response. We're going to put warm blankets on if they need them. Warm the fluids, put lights on them. Ambient room temperature should be increased. 5 things that we need to get for them for their care are labs, potentially a Foley, nasogastric tube, telemetry, and pulse ox. We also want to resuscitate and give pain relief and reassess everything that we do. We're also going to look at their history and their assessment. So your ABCDEFGH is alertness and airway with cervical spine stabilization and/or immobilization, breathing, circulation, disability, exposure and environmental control, facilitate adjuncts and family, get resuscitative adjuncts, and your head-to-toe assessment as well as the history. Your primary survey focuses on airway, breathing, circulation, or your ABCs, disability, which is your neuro component, exposure, facilitation of adjuncts and family, and to get the resuscitative adjuncts. We also want to control any external hemorrhage. If we do, we're going to reprioritize, and instead of doing ABCs, our actions are CABC. We're going to apply direct pressure and put on a pressure dressing. The primary survey is discussed in 68.3, and again, it focuses on your airway, breathing, and circulation. If we do have that uncontrolled bleed, we reprioritize. So we're assessing the A through I, but our actions are changed to reprioritization of your circulation and then your airway, breathing. The primary survey aims to identify life-threatening conditions so that appropriate interventions can be started. You can identify life-threatening conditions related to ABCs on table 68.4 at any point during the primary survey. When this occurs, we're going to start interventions immediately before moving to the next step of the survey. So we can't move to the next letter until we fix the letter we're in that's broken. The alertness level of the patient can be an important factor for selecting appropriate airway interventions. We want to determine their level of consciousness, by assessing the patient's response to verbal and/or painful stimuli. So a simple mnemonic that we can use is AVPU. A is, are they alert? V is, are they responsive to voice? P is, are they responsive to pain? And U is, are they unresponsive? And this means that they can only be one of the four. They can't be more than one. Okay. We also want to look to see if their airway is obstructed. Cause of nearly all immediate trauma deaths is airway obstruction. Sources could be saliva, bloody secretions, vomitus, laryngeal trauma, dentures, facial trauma, fractures, and dentures. Patients who are at risk for airway compromise are those who have seizures, a drowning victim, anaphylaxis, a foreign body obstruction, and cardiopulmonary arrest. So again, A is alertness and airway. Airway maintenance should progress rapidly from the least to the most invasive method. Treatment includes opening the airway using the jaw thrust maneuver. The jaw thrust maneuver is the recommended procedure for opening the airway of an unconscious patient with a possible neck or spinal injury, so not the head tilt, chin lift. The patient should be lying supine with the rescuer kneeling at the top of the head. The rescuer places one hand on each side of the patient's head, resting his or her elbows on the surface. And then the rescuer grasps the angles of the patient's lower jaw and lifts the jaw forward with both hands without tilting the head. Signs and symptoms of airway compromise include dyspnea, inability to speak, gasping or agonal breaths. And remember, gas or agonal breaths are not breathing. That's actually a reflex. Foreign body in the airway or trauma to the neck or face. So how are we going to treat them? It includes opening the airway using the jaw thrust maneuver, avoiding hyperextension of the neck, suctioning and/or removing the foreign body, inserting a nasopharyngeal or an oropharyngeal airway. Oropharyngeal is only for unconscious patients, and potentially endotracheal intubation. If intubation is impossible because of airway obstruction, an emergency cricothyrotomy or a tracheotomy is performed. We're going to ventilate them with 100% O2 using a bag valve mask before intubation or the cricothyrotomy. Rapid sequence intubation is a preferred procedure for securing an unprotected airway in the ED, and we are going to sedate them and paralyze them. It involves the use of sedation such as midazolam or Versed, or an anesthesia, etomidate or amidate, and paralysis, succinylcholine or nectidine. These drugs aid in intubation and reduce the risk of aspiration and airway trauma. We're going to stabilize the cervical spine, keeping that head maintained in a neutral position, and or immobilizing during the assessment of the airway. At the scene of the injury, the C-spine is immobilized with a rigid cervical collar or a cervical immobilization device, a CID, and these are known as head blocks. We're finally going to secure the patient's forehead to the backboard. We're not going to use sandbags because the weight of the bags could move the head if the patient is log rolled and then cause spinal injury. We're going to assess the breathing. We're going to assess for dyspnea, cyanosis, paradoxical asymmetric chest wall movement, decreased or absent breath sounds, visible wounds to the chest wall, cyanosis, tachycardia, and hypotension. And we're going to keep that head of the bed flat to continue to monitor their airway and their breathing. So since we fixed the A, we're moving on to breathing. Every critically injured or ill patient has an increased metabolic and oxygen demand and should be supplemented with oxygen. We're going to give them high flow oxygen 100% via non-rebreather mask and monitor the patient's response. We are going to assess for life-threatening conditions such as a flail chest, a tension pneumothorax, which can severely and quickly compromise ventilation. Interventions may include a bag valve mask ventilation with 100% O2, needle decompression, intubation, and treatment of the underlying cause. Remember, breathing changes can occur with fractured ribs, pneumothoraces, penetrating injuries, allergic reactions, pulmonary embolus, and asthma attacks. So we're going to assess to see if we can determine if any of these are occurring. Next, we're going to move on to circulation. An effective circulatory system includes the heart, intact blood vessels, and adequate blood volume. Uncontrolled internal or external bleeding places an individual at risk for a hemorrhagic shock. We're going to check their central pulses, for example, the carotid, because peripheral pulses may be absent due to direct injury or vasoconstriction. Do they have an altered mental status and a delayed cap refill, which is longer than 3 seconds? These are common signs of shock. When evaluating capillary refill in cold environments, remember that a cold temperature will delay the refill. So we're not only going to check their pulses, but we're also going to assess their skin, the color, the temperature, and the moisture. And remember, changes in level of consciousness are usually due to changes in their ability to get the oxygen that they need to their brain. It's going to affect their mental status and also their cap refill, which is a circulatory problem. So we're going to insert IV lines into the veins in the upper extremities, unless contraindicated, such as a massive fracture or an injury that affects the limb circulation. We're going to insert 2 large bore IVs, either 14 or 16 gauge, and start aggressive fluid resuscitation using normal saline or lactated ringer solution. We're going to consider intraosseous or central venous access if we can't rapidly obtain a venous access. We're going to give type-specific packed red blood cells. If it's an emergency, such as a life-threatening situation, we can give an uncrossed matched blood, for example, O negative, if immediate transfusion is warranted. We can put on pelvic splints or belts for the pelvic fracture, which may be used for bleeding with hypotension. And remember, if you have a fracture of your pelvis, you can lose up to 1.5 liters. You break both your femurs, you can have 1.5 liter of blood loss from each one of them as well. We're going to move on to disability. That's going to be measured by the patient's level of consciousness. We're going to conduct a brief neurologic examination, and the patient's level of consciousness is a measure of the degree of disability. We're going to use a Glasgow Coma Scale to determine their level of consciousness. Although the GCS is not accurate for intubated or aphasic patients, it is a standardized tool. It allows for consistent communication among the interprofessional care team, and we can assess the pupils for size, shape, equality, and reactability as well. When we're looking at the pupils, you need to determine why the constriction or dilatation may be occurring. If they're constricted, it could be because they're bored with what's happening, their mind is not working very hard, they're not sure about what they're doing, they're disgusted by what they see, they don't recognize anything, and their mind is relatively inactive now. On the other hand, if we have dilated pupils, they could be interested in what they're seeing, they're thinking hard about something, they have confidence in their action and belief, they're attracted to the situation, they've seen or heard this before, and they're thinking about something stimulating. So this is an example of the GCS, and you can see that you could be dead and still have a score of 3. But what we're looking at is best eye-opening, best verbal response, and best motor response. Know that if they have a score of 8, you're going to intubate. Your best possible score is 15, and they're spontaneously doing everything that you ask of them. So we want to expose and control their environment to keep them warm. We want to remove all trauma patients' clothing to perform a thorough physical assessment. This often requires cutting off their clothing. Be careful not to cut through any area that may provide forensic evidence, such as a bullet hole. Don't remove any impaled objects for any reason. Removing them could result in a serious bleed and further injury. Once the patient is exposed, we're going to use warm blankets, overhead warmers, and warmed IV fluids to limit the heat loss and prevent hypothermia and maintain privacy. We're also going to facilitate adjuncts and family. The adjuncts that we may need to facilitate include a blood pressure, which is bilateral, your heart rate, your respiratory rate, oxygen saturation, and temperature. So we're going to get a full set of vitals, and a temperature. Rectal is usually the best. If the patient has sustained or is suspected of having sustained chest trauma, or if the blood pressure is abnormally high or low, we're going to obtain the blood pressure in both arms. Family presence is extremely important to clients and their families. Research supports the benefits of patients, caregivers, and staff of allowing family presence during resuscitation and invasive procedures. Patients report that caregivers provide comfort, such as advocates for them, and help remind the interprofessional care team of their personhood. Caregivers who wish to be present during invasive procedures and resuscitation view themselves as active participants in the care process. They also believe that they can comfort the patient and that it's their right to be with the patient. Nurses report that family members serve as patient helpers, such as providing support, and staff helpers, acting as a translator. It's essential to assign a member of the interprofessional team to explain care delivered and answer questions should a caregiver request family presence during resuscitation or invasive procedures. And then we're going to get the resuscitative adjuncts, which is the LMNOP. L is laboratory studies, such as type and cross, complete blood count, metabolic panel, blood alcohol, toxicology, screening, arterial blood gases or ABGs, coagulation profile, cardiac biomarkers, and pregnancy, urine pregnancies. M is monitor their EKG for heart rate and rhythm. N is nasogastric tube to decompress and empty the stomach, reduce the risk of aspiration, and test the contents for blood. We're going to place an orogastric tube in a patient with a significant head or facial trauma, since the nasogastric tube could actually enter the brain. So if they have a basilar skull fracture, we are not going to put an NG in. O is oxygenation and ventilation assessment. We're going to continuously monitor the O2 sat and end-tidal carbon dioxide if appropriate. And P is pain. We're going to consistently assess their pain and manage it, either pharmacologically or non-pharmacologically. Pain is a primary complaint of most patients who come to the ED. Provision of comfort measures is critical when caring for patients in the ED. Many have developed pain management guidelines for nurses to treat pain early, beginning at triage. Pain management strategies should include a combination of pharmacologicals, such as nonsteroidal anti-inflammatory drugs and IV opioids, and non-pharmacological, such as distraction, positioning, music. You can play a key role in ongoing pain management because of your frequent contact with your patients. General comfort measures such as providing verbal reassurance, listening, reducing stimuli such as dimming the lights, warming the blankets, and developing a trusting relationship with the patient and caregiver should be provided to all patients in the ED. Additional measures include splinting, elevating, and icing injured extremities as appropriate, but then you want to always make sure that you are reassessing anything that you try to fix. Secondary survey. So everything that we've just discussed is your primary survey, so now we're going into your secondary. The history and mechanism of the injury or illness provides clues to the cause of the crisis, such as were the injuries self-inflicted or a result of abuse, and suggests specific assessment and interventions. The patient may not be able to give a history, however, caregivers, friends, bystanders, and pre-hospital personnel can often provide necessary information. Pre-hospital information focuses on the mechanism and the pattern of injury, injury sustained, vitals taken, treatments initiated, and patient responses. Details of the incident are extremely important because the mechanism of injury and injury patterns can predict specific injuries. For example, a restrained front seat passenger may have a head injury or knee, femur, or hip fractures from hitting the dashboard and an abdominal injury from the seatbelt. And the airbag. If there are deaths at the scene, the patient is at a higher risk for significant injury. And if they have more than 12 inches of intrusion, which means the car goes in more than 12 inches. We're also going to do that head-to-toe assessment from the head, neck, and face, the chest, the abdomen and flanks, the pelvis and perineum, the extremities last, and then the eye is inspect posterior surfaces. So what is a history taking? We're asking questions of patients to obtain information and hidden diagnoses. We're going to gather data, both objective and subjective, for the purpose of generating differential diagnoses, evaluating progress following a specific treatment, procedure, and evaluating the change in their condition or the impact of the specific disease process. We can also use sample, which is symptoms, allergies, medication history, and that includes both prescribed, over-the-counter, herbs, minerals, vitamins. We're going to check past health history, last meal or oral intake, so intake and output, and then events or environmental factors leading to the illness or the injury. This is table 68.5, and our pre-hospital personnel can provide this detailed description of their general condition, their level of consciousness, and apparent injuries. If they are emergently ill, we're going to obtain a thorough history from the caregivers or friends after the patient is taken to the treatment area. With your sample, symptoms are the symptoms that are associated with the injury or illness, allergies due to drugs, food, latex, environment, and what's their tetanus status? What's their medication history? What's their past health history? Do they have pre-existing medical or psychiatric conditions, previous surgeries, smoking history, recent use of drugs or alcohol, last menstrual period, baseline mental status? What was their last meal, oral intake, and output? And then E again is events or environmental factors leading to the illness or the injury. We're going to do a brief systematic process to identify all of the injuries. Again, head, neck, and face, chest, abdomen and flanks, pelvis and perineum, extremities, and then eyes inspect posterior surfaces, which you're going to use a team to log roll them. The secondary survey begins after addressing each step of the primary survey and starting any life-saving interventions. The secondary survey is a brief, systematic process that aims to identify all injuries. When we assess a patient for general appearance, skin color, and temperature, we're also going to check the eyes for extraocular movements. A disconjugate gaze is an indication of neurologic damage. We're going to look for battle signs or bruising directly behind the ears, which may indicate a fracture of the base of the posterior portion of the skull. You can also see raccoon eyes or periorbital ecchymoses, which is usually an indication of a fracture of the base of the frontal portion of the skull. Both of those are late signs. We're going to check for the ears for blood and cerebrospinal fluid. We do not ever block that clear drainage from the ear or the nose. We're going to assess the airway for foreign bodies, bleeding, edema, and loose or missing teeth, and check for the ability to open the mouth and swallow. We're going to inspect the neck for bruising, edema, bleeding, or distended neck veins. We're going to palpate the trachea to determine whether it's midline. A deviated trachea may signal a life-threatening tension pneumothorax and must be dealt with immediately. They can also have subcutaneous emphysema, which can indicate laryngotracheal disruption. A stiff or painful neck may signify a fracture of one or more cervical vertebrae. We're going to protect the cervical spine using a C-collar, and we're going to suction positioning if that is needed, or we're going to do supine positioning if that is needed. We're going to inspect the chest for paradoxical chest movements and large sucking chest wounds. We're going to palpate the sternum, clavicles, and ribs for deformity, point tenderness, and crepitus. We're going to auscultate breath sounds and heart sounds. In addition to tension pneumothoraces and open pneumothoraces, we're going to evaluate the patient for rib fractures, pulmonary contusions, blunt cardiac injury, and a hemothorax. We're going to obtain a chest X-ray and a 12-lead EKG, particularly on patients with known or suspected heart disease. The EKG can help detect dysrhythmias and signs of myocardial ischemia and infarction. And as you can see here, this is a dressing that we are going to put onto a hole or a sucking chest wound. And what you want to do is make it three-sided so that the air can get out, it just can't get in. The abdomen and the flanks are more difficult to assess. Frequent evaluation for subtle changes in the abdomen are essential. Motor vehicle crashes and assaults can cause blunt trauma. Penetrating trauma tends to injure specific solid organs, such as the spleen, based on their trajectory. We're going to stabilize any impaled objects. They need to be removed in a controlled environment, such as an operating room. We're going to inspect the abdomen for bruising, petechiae, and ecchymoses. We're going to auscultate for bowel sounds. Decreased bowel sounds may indicate a temporary paralytic ileus, and bowel sounds in the chest may indicate a diaphragmatic fracture or rupture. We're going to percuss the abdomen for distension. Tympany is due to excessive air, and dullness is due to excessive fluid, and palpate for tenderness. If you suspect an intra-abdominal hemorrhage, we're going to do a focused abdominal sonography for trauma, which is the FAST, to determine blood in the peritoneal space, or a hemoperitoneum. This procedure is non-invasive and performed quickly at the bedside. A FAST cannot rule out a retroperitoneal bleed. If we suspect retroperitoneal bleeds, then we're going to get a CT scan. For the pelvis and the peritoneum, we are going to gently palpate the pelvis to determine stability. We're not ever going to rock it. Pain may indicate a pelvic fracture and the need for an x-ray. We're going to inspect the genitalia for bleeding, priapism, and obvious injuries. We're going to assess for bladder distension, hematuria, dysuria, or inability to void. The healthcare provider may perform a rectal examination to check for blood, a high-riding prostate gland, such as with a urethral injury, and loss of sphincter tone, which could indicate a spinal cord injury. We're going to assess the upper and lower extremities for point tenderness, crepitus, and deformities. We can splint the injured extremities above and below the injury to decrease further soft tissue injury and pain if it's not done pre-hospital. Grossly deformed, pulseless extremities should be realigned by the healthcare provider and then splinted. We're going to check pulses before and after movement or splinting of an extremity. A pulseless extremity is a time-critical emergency. We're going to mobilize and elevate injured extremities and apply ice packs. Prophylactic antibiotics are ordered for open fractures, and we're also going to assess extremities for compartment syndrome. This occurs as a pressure and swelling increase inside a section of the extremity, for example, the anterior compartment of the lower leg, over several hours. This compromises the viability of the muscles, the nerves, and the arteries. Potential causes of compartment syndrome include crest injuries, fractures, edema, burns, and hemorrhage. And this is an example of someone who is suffering from a compartment syndrome, and the treatment of choice is a fasciotomy. Our last letter is I for inspect the posterior surfaces. So we're going to log roll the patient while maintaining cervical spine immobilization to inspect the posterior surfaces. This will require a minimum of 3 to 4 people. We're going to support the head, and the person at the head is going to be leading the call of when we turn the patient. We're going to look for ecchymoses, abrasions, puncture wounds, cuts, obvious deformities, and we will palpate the entire spine for malalignment, deformity, and pain. Once the secondary survey is complete, we're going to record all the findings. We're going to provide tetanus prophylaxis based on the vaccine history and the condition of any wounds. Regardless of the patient's chief complaint, ongoing monitoring and evaluation of interventions are critical. We want to provide appropriate care and assess the patient's response. We're going to evaluate the airway patency and the effectiveness of breathing. That's always our highest priority. We're going to monitor respiratory rate and rhythm, O2 sat, and ABGs if ordered, to evaluate the patient's respiratory status. We're going to obtain a portable chest x-ray to confirm exact placement of the tubes, such as your endotracheal tube and your gastric tube. We're going to closely monitor the LOC, or level of consciousness, vital signs, the quality of peripheral pulses, and skin temperature, color, and moisture for key information about circulation and perfusion. If we can, we will insert an indwelling catheter to decompress the bladder so we can monitor their urine output, especially if we are giving them boluses, and check for hematuria. Don't ever insert an indwelling catheter if there is blood at the meatus, the urinary meatus, because that could be indicative of a urethral tear, or if there's scrotal hematoma or perineal ecchymoses are present. Men with a high-riding prostate gland on rectal examination are at risk for urethral injuries, and the healthcare provider may order a retrograde urethrogram before inserting a catheter. Depending on the patient's injuries or illness, the patient may be transported for diagnostic tests, such as a CT or angiography, or to the operating room for immediate surgery. They may be admitted to an intensive care, telemetry, or general unit, or transferred to another area of the facility, or to a hospital of higher care. You may go to critically ill patients on transports. You are responsible for monitoring the patient during the transport, notifying the interprofessional care team should the patient's condition become unstable, and starting basic and advanced life support measures are needed. Many patients arrive in the ED in cardiac arrest. Patients with non-traumatic out-of-hospital cardiac arrest benefit from a combination of good chest compressions and rapid defibrillation, therapeutic hypothermia, and supportive care. Targeted temperature management is done for 24 hours after the return of spontaneous circulation, or ROSC, and decreases mortality rates and improves neurologic outcomes in many patients. It's recommended for all patients who are comatose or who do not follow commands after return of spontaneous circulation, or ROSC. The goal core temperature is 89.6 to 93.2 degrees Fahrenheit, or 32 to 34 degrees Celsius, but research has noted that 36 degrees Celsius has similar outcomes. So we can use cold saline infusions or surface cooling devices such as the Arctic Sun or the Barricauger. Patients require intubation, mechanical ventilation, invasive monitoring, and continuous assessment. The 3 phases of hypothermia are induction, maintenance, and rewarming. The induction phase begins in the ED. Patients have to be intubated with mechanical ventilation, invasive monitoring, and continuous monitoring. Mechanical chest compression devices are often used to provide chest compressions both pre-hospital and in the emergency department. This is an example of a mechanical chest compression device that we have at St. Francis. It's the Lucas 2. It's a mechanical chest compression device that can be used so it can free up staff so they don't have to be performing CPR. Application of the Lucas on a patient during cardiopulmonary resuscitation requires the expertise of the individuals who are putting them on. There are some individuals that may be too large or too small, and this device will not be effective. So you just have to be able to know how to use this device and know to look for complications. So we have a 32-year-old man who arrives in the ED via paramedics. A neighbor found him lying on the rocks in the rock garden. He had fallen off the roof while fixing the shingles on his house. His femur is protruding through the skin. The paramedics report that he was found in a large pool of blood. He's unresponsive with a blood pressure of 60/42, and his heart rate is 168. So you can already be thinking of the potential injuries that he might be experiencing. So what potential life-threatening injuries does he have? He has a head injury, abdominal trauma, and internal bleeding. What's our priority of care? Airway, breathing, and circulation. What interventions are needed immediately? Intubation, ventilation, fluid replacement, and cross and type for blood. And if we can't, then we will go ahead and give O negative. Unfortunately, a number of patients will not benefit from the skill, expertise, and technology available in the ED. So it's important for us to deal with our feelings about sudden death so that we can help caregivers begin the grieving process. We need to recognize the importance of certain hospital rituals to help caregivers grieve. These can include collecting the personal belongings, viewing the body, and making mortuary arrangements. That the death must be seen real so that the caregivers can begin to accept the death. So we as healthcare providers play a significant role in providing comfort to the surviving loved ones after a death in the ED. Whenever possible, we need to provide an area for privacy and, if appropriate, arrange for a visit from the chaplain. We may need to contact medical examiner or coroner. Autopsies may be arranged at the family's request or in the case of a death within 20 hours of ED admission or from suspected trauma or violence, such as a gunshot wound. Many patients who die in the ED could potentially be candidates for non-heart beating donation. Certain tissues and organs, such as corneas, heart valves, skin, bone, and kidneys, can be harvested from patients after death. Organ procurement organizations, or OPOs, assist in the process of screening potential donors, counseling donor families, obtaining informed consent, and harvesting organs from patients who are on life support or who die in the ED. Approaching caregivers about donation after an unexpected death can be distressing to both staff and the caregivers. For many individuals, the act of donation may be the first positive step in the grieving process. So now we're going to move on to environmental emergencies. Increased interest in outdoor activities such as running, hiking, cycling, skiing, and swimming has increased the number of environmental emergencies seen in the emergency department. Illness or injury may be caused by the activity, exposure to weather, or attack from various animals or humans. Specific environmental emergencies discussed in this presentation will include heat-related emergencies, cold-related emergencies, submersion injuries, bites, and stings. Brief exposure to intense heat or prolonged exposure to less intense heat leads to heat stress. This occurs when thermoregulatory mechanisms such as sweating, vasodilation, and increased respirations cannot compensate for exposure to increased ambient temperatures. Ambient temperature is a product of environmental temperature and humidity. Strenuous activities in hot or humid environments, clothing that interferes with perspiration, high fevers, and pre-existing illnesses predispose individuals to heat stress. Table 68.8 presents the management of heat-related emergencies. Ambient temperature is a product, again, of the temperature and the humidity, and we have to be aware when the patients come in with this, and so that we can educate them on performing less strenuous activity when the heat is high as well as the humidity. So Table 68.7 identifies risk factors for heat-related emergencies. It can be the ones that are at most risk are those with young age, such as infant or older adults. Could also be due to environmental conditions, like I said, high environmental temperatures and high relative humidity. If you are hot and you are working out and the humidity is extremely high, that means that the pressure on the outside of your body is higher than the ability to sweat and on your internal part of your body. So the pores cannot open and allow you to sweat, and so your body temperature just increases, and that can be a very dangerous situation if you're exercising. Pre-existing illnesses such as cardiovascular disease, cystic fibrosis, dehydration, diabetes mellitus, obesity, previous stroke or other central nervous system lesions, skin disorders such as large burn scars can also affect your ability to handle heat. Prescription drugs such as anticholinergics, antihistamines, anti-Parkinson disease drugs, antispasmodics, beta blockers, diuretics, phenothiazines, tricyclics, alcohol, street drugs such as amphetamines, Jimson weed, LSD, PCP, ecstasy, all of those can increase your heat in your body as well as any type of hallucinogen. Environmentally, if you aren't used to the area, you lack acclimatization, physical exertion, especially during hot weather, and prolonged exposures to extreme temperatures. Also trauma, such as head injuries, spinal cord injuries, Metabolic disorders such as dehydration, diabetes, thyrotoxicosis can all lead to heat-related emergencies. Heat cramps are severe cramps in large muscle groups fatigued by heavy work. Cramps are brief and intense and tend to occur during rest after exercise or heavy labor. Nausea, tachycardia, pallor, weakness, and profuse diaphoresis are often present. The condition is seen most often in healthy acclimated athletes with inadequate fluid intake. Cramps resolve rapidly with rest and oral or parenteral replacement of sodium and water. Elevation, gentle massage, and analgesia minimize the pain associated with heat cramps. So it is appropriate to take analgesia for your cramps that you may have. We want to instruct the patient to avoid strenuous activity for at least 12 hours. Discharge teaching should emphasize salt replacement during strenuous exercise in hot, humid environments. And we can also recommend the use of commercially prepared electrolyte solutions, such as sport drinks. But what you want to also do is make sure that they don't just drink sport drinks. They should drink a combination of water and the sport drinks so that you don't overburden your system with excesses of one or the other fluids. And again, we can use for heat cramps, elevation, gentle massage, and analgesia. This is appropriate for heat cramps. For prolonged exposure to heat over hours or days, clinical syndrome is characterized by fatigue, nausea, vomiting, extreme thirst, feelings of anxiety. So clinically, they are going to be tachycardic. They can have dilated pupils, mild confusion, ashen color, profuse diaphoresis. Hypotension and mild to severe temperatures elevation are 99.6 to 105.8 Fahrenheit or 37.5 to 41 degrees Celsius, and this is due to dehydration. So we're going to place the patient in a cool area and remove the constrictive clothing. We want to monitor their ABCs, including their heart dysrhythmias due to electrolyte imbalances, start oral fluid and electrolyte replacements unless the patient is nauseated. Salt tablets are not used because of the potential gastric irritation and hyponatremia or hypernatremia. We're going to start a 0.9% normal saline IV solution if oral solutions are not tolerated. An initial fluid bolus may be needed to correct hypotension. However, we're going to correlate the fluid replacement to clinical and lab findings. We can also place a moist sheet over the patient to decrease their core temperature through evaporation, heat loss, and we're going to consider hospitalization for the older adult, the chronically ill, or those who do not improve within 3 to 4 hours. Your heat stroke is your most serious form of heat stress. This is a failure of the hypothalamic regulatory processes, and what we're going to see is a medical emergency because of the vasodilatation, the increased sweating, and respiratory rate to deplete fluids and electrolytes, specifically sodium. Eventually, the sweat glands will stop functioning and the core temperatures will increase rapidly within 10 to 15 minutes. The patient has a core temperature greater than 105.8 or 41 degrees Celsius. They're going to have altered mental status, absence of perspiration, and circulatory collapse. Their skin will be hot, dry, and ashen. A range of neurologic symptoms occur, such as hallucinations, loss of muscle coordination, and combativeness, because their brain is extremely sensitive to thermal injury. Cerebral edema and hemorrhage can occur as a result of direct thermal injury to the brain and decreased cerebral blood flow. Older adults and those with diabetes mellitus, chronic kidney disease, cardiovascular disease, pulmonary disease, or other physiologic compromise are particularly vulnerable. So what's going to determine their prognosis is relating to their age, their baseline health status, and their length of exposure. And death is related to the amount of time the patient's body's temperature remains elevated. We're going to stabilize their ABCs. We want to rapidly decrease their core temperature, so we're going to remove their clothing, Cover with wet sheets and spray with lukewarm water. Place them in front of a large fan. Immerse them in cool water. Apply ice packs to the groin and axilla. And in refractory cases, we may have to do peritoneal or rectal lavage with ice fluids. We're also going to give 100% O2 to compensate for the patient's hypermetabolic state. Ventilate them with a BVM or intubate them and mechanically ventilate them. We're going to correct their fluid and electrolyte imbalances and start continuous EKG monitoring for dysrhythmias. And again, we discussed the various ways that we can cool them. Whatever method is selected, we want to closely monitor the patient's temperature and control their shivering, because that's only going to increase their temperature. Shivering increases core temperature due to the heat generated by muscle activity, and this complicates our cooling efforts. We could give Thorazine IV to control the shivering. Antipyretics are not effective in this situation because the elevated temperature is not related to infection. So remember, heat cramps, we can give ibuprofen, but we cannot give an antipyretic to somebody who's got heat stroke. That's not going to help them at all. We want to monitor the patient for signs of rhabdomyolysis, which is a serious syndrome caused by the breakdown of skeletal muscle. The muscle breakdown leads to myoglobinuria, and this places the kidneys at risk for acute kidney injury. We want to carefully monitor their urine for color. We want to make sure that we don't want it to be tea-colored. We're going to check the amount, the pH, and the myoglobin. We're going to obtain clotting studies to monitor the patient for signs of disseminated intravascular coagulation, or DIC. And we want to do patient and caregiver teaching to focus on how to avoid future problems. Provide essential information regarding proper hydration during hot weather and physical exercise. Instruct the patients on the early signs and interventions for heat-related stress. Now we're going to go to the cold-related emergencies, which could be localized, systemic, and the contributing factors. Cold injuries may be localized, which is frostbite, or systemic, which is hypothermia. Contributing factors include age, duration of exposure, environmental temperatures, homelessness, pre-existing conditions such as diabetes mellitus, peripheral vascular disease, drugs that suppress shivering, such as opioids, psychotropic agents, and antiemetics, as well as alcohol intoxication. Alcohol causes peripheral vasodilation, increases sensation of warmth, and depresses shivering. Smokers have an increased risk of cold-related injury because of the vasoconstrictive effects of nicotine. Frostbite is true tissue freezing that results in formation of ice crystals in the tissues and cells. Peripheral vasoconstriction is the initial response to cold stress and results in a decrease in blood flow and vascular stasis. As cellular temperature decreases and ice crystals form in intracellular spaces, the organelles are damaged and the cell membrane is destroyed, and this then results in edema. Other factors that affect severity include skin color. Dark-skinned people are more prone to frostbite, lack of acclimatization, previous episodes, exhaustion, and poor peripheral vascular status. This is an example of frostbite 24 hours after the frostbite has occurred. And this is an example of 6 weeks after the same frostbite on the previous slide. And you can definitely see the necrosis, and probably we're going to have some amputation occur. Superficial frostbite involves skin and subcutaneous tissue, usually the ears, nose, fingers, and toes. The skin appearance ranges from waxy pale yellow to blue to mottled, and the skin feels crunchy and frozen. The patient may complain of tingling, numbness, or a burning sensation. So we want to handle the area carefully and never squeeze, massage, or scrub the injured tissue because it is easily damaged. We want to remove clothing and jewelry because they may constrict the extremity and decrease circulation. Immerse the affected area in circulating water that is temperature controlled from 98.6 to 104 Fahrenheit or 37 to 40 Celsius. We want to use warm soaks to the face. The patient often experiences a warm, stinging sensation as tissue thaws. The blisters form within a few hours. The blisters should be debrided and a sterile dressing applied. We want to avoid heavy blankets and clothing because friction and weight can lead to sloughing of damaged tissue. Rewarming is extremely painful, and residual pain can last weeks or even years. We want to give analgesia and tetanus prophylaxis as appropriate and evaluate the patient with superficial frostbite for systemic hypothermia. Deep frostbite involves muscle, bone, and tendons. The skin is white, hard, and insensitive to touch. The area has the appearance of deep thermal injury with mottling gradually progressing to gangrene. We want to immerse the affected extremity to a temperature-controlled circulating water, again 98.6 to 104 or 37 to 40 Celsius until flushing occurs distal to the injury. After rewarming, the extremity should be elevated to reduce edema. Significant edema may begin within 3 hours with blistering in 6 hours to days. IV analgesia is needed in severe frostbite because of the pain associated with tissue thawing. We're going to give tetanus prophylaxis and evaluate the patient for systemic hypothermia. The patient may be admitted to the hospital for observation with bed rest, elevation of the injured part, and prophylactic antibiotics if the wound is at risk for infection. Amputation may be required if the injured area is untreated or the treatment is unsuccessful, and it can take as long as 90 days for the full demarcation of the necrotic area. Hypothermia occurs when heat produced by the body cannot compensate for the heat lost to the environment. Most body heat is lost as radiant energy, with the greatest loss from the head, the thorax, and the lungs with each breath. Wet clothing increases evaporative heat loss 5 times greater than normal. Immersion in cold water, such as drowning, increases evaporative heat loss 25 times greater than normal. Environmental exposure to freezing temperatures, cold winds, and wet terrain, plus physical exhaustion, inadequate clothing, and inexperience predisposes individuals to hypothermia. Older adults are more prone to hypothermia because of the decreased body fat, diminished energy reserves, decreased basal metabolic rate, decreased shivering response, decreased sensory perceptions, chronic medical conditions, and drugs that alter body defenses. Hypothermia mimics cerebral and metabolic disturbances, causing ataxia, confusion, and withdrawal, so the patient may be misdiagnosed. Peripheral vasoconstriction is the body's first attempt to conserve heat. As cold temperatures persist, shivering and movement are the body's only mechanisms for producing heat. Patients with mild hypothermia, which is 93 to 95 Fahrenheit or 33.9 to 35 Celsius, have shivering, lethargy, confusion, rational to irrational behavior, and minor heart changes. Moderate hypothermia is 89 to 93 Fahrenheit or 30 to 33.9 Celsius. This causes rigidity, bradycardia, slowed respiratory rate, blood pressure obtainable only by a Doppler, metabolic and respiratory acidosis, and hypovolemia. Shivering diminishes or disappears at core temperature of 86 degrees Fahrenheit or 30 Celsius. As core temperature drops, metabolic rates decreases 2 to 3 times. The cold myocardium is extremely irritable, making it vulnerable to dysrhythmias, such as atrial and ventricular fibrillation. Decreased renal blood flow decreases glomerular filtration rate, which impairs water reabsorption and leads to dehydration. The hematocrit increases as intravascular volume decreases. Cold blood becomes thick and acts as a thrombus, placing the patient at risk for stroke, myocardial infarction, pulmonary emboli, and renal failure. Decreased blood flow leads to hypoxia, anaerobic metabolism, lactic acid accumulation, and metabolic acidosis. Severe hypothermia is a temperature below 86 Fahrenheit or 30 Celsius and makes a person appear dead and is a potentially life-threatening situation. Metabolic rate, heart rate, and respirations are so slow that they may be difficult to detect. Reflexes are absent and the pupils are fixed and dilated. Profound bradycardia, ventricular fibrillation, or asystole may be present. Every effort is made to warm the patient to at least 86 degrees Fahrenheit or 30 Celsius before the person is pronounced dead. So you're not dead until you're warm and dead. The cause of death is usually refractory ventricular fibrillation. As the core temperature decreases, the metabolic rate decreases 2 to 3 times. And then that cold myocardium causes dysrhythmias, decreased renal flow, decreased GFR, and decreased water absorption, leading to dehydration. Increased hematocrit causes decreased intravascular volume, and cold blood is thick, so it acts as a thrombus. So then the patient is at risk for stroke, myocardial infarction, pulmonary embolus, and renal failure. Decreased blood flow leads to hypoxia, anaerobic metabolism, lactic acid accumulation, and metabolic acidosis. Treatment of hypothermia focuses on management and maintaining ABCs, rewarming the patient, correcting dehydration and acidosis, and treating cardiac dysrhythmias. So we can use passive or active external rewarming for mild hypothermia, and there are more treatments as well on table 68-9. But when we are warming them up, we're warming them up slowly so as not to cause more problems. For mild hypothermia, we're going to use passive or spontaneous rewarming, which involves moving the patient to a warm, dry place, removing damp clothing, using radiant lights, and placing warm blankets on the patient. Active external or surface rewarming involves fluid or air-filled warming blankets or warm water immersion, which is 98.6 to 104 Fahrenheit, 37 to 40 Celsius. We want to closely monitor the patient for marked vasodilatation and hypotension during the rewarming phase. For moderate to severe hypothermia, we refer to the application of heat directly to the core. Techniques include heating, which is up to 111.2 degrees Fahrenheit or 44 degrees Celsius, humidified O2, warmed IV fluids up to 98.6 Fahrenheit, 37 Celsius, peritoneal lavage with warm fluids up to 113 Fahrenheit, 45 Celsius, and extracorporeal circulation with cardiopulmonary bypass, rapid fluid infuser, or hemodialysis. We want to gently handle the patient because we want to prevent the stimulation of the cold myocardium and put them into ventricular fibrillation. We want to carefully monitor their core temperature during rewarming procedures. Patients with moderate to severe hypothermia should have the core warmed before the extremities. Rewarming places the patient at risk for afterdrop, a further drop in core temperature, and this occurs when cold peripheral blood returns to the central circulation. Rewarming shock can produce hypotension and dysrhythmias. Discontinuing active rewarming once the core temperature reaches 90 degrees to 95 degrees Fahrenheit or 32.2 to 35 Celsius. Patient teaching focuses on how to avoid future cold-related problems. Essential information includes dressing in layers for cold and weather, covering the head, carrying high carbohydrate foods for extra calories, and developing a plan for survival should an injury occur when in an extreme environment. Submersion injury results when a person becomes hypoxic as a result of submersion in a liquid, usually water. More than 50,000 submersion events and approximately 3,500 deaths from drowning occur each year in the U.S. Most of the victims are children younger than 5 years of age or boys and men between 15 and 25. The primary risk factors for submersion injury include inability to swim, use of alcohol or drugs, trauma, seizures, hypothermia, stroke, and child neglect. You can see Table 6810 in the textbook. Risk factors include inability to swim or exhaustion, entrapment or entanglement with objects in water, loss of ability to move, such as trauma, hypothermia, MI, or stroke, seizures, use of alcohol or drugs, and child neglect. Aggressive resuscitation in pre-hospital phase will improve the chances of survival. Drowning is a process of experiencing respiratory impairment after submersion in water or other fluids. Submersion in cold water below 32 Fahrenheit or 0 Celsius may slow the progression of hypoxic brain injury. Most drowning victims do not aspirate any liquid due to laryngospasm. If liquid is aspirated, it's in small amounts, for example, 4 mils per kilo. Drowning victims who do aspirate water develop pulmonary edema. Regardless of what type of fluid is aspirated, the end result can be acute respiratory distress syndrome. You look at the pathophysiology of submersion injury. The osmotic gradient caused by aspirated fluid leads to fluid imbalances in the body. Hypotonic fresh water is rapidly absorbed into the circulatory system through the alveoli. Fresh water is often contaminated with chlorine, mud, or algae. This causes the breakdown of lung surfactant, fluid seepage, and pulmonary edema. Hypertonic salt water draws fluid into the vascular space into the alveoli, impairing alveolar ventilation and resulting in hypoxia. The figure above shows the pulmonary effects of saltwater and freshwater aspiration. The body attempts to compensate for hypoxia by shunting blood to the lungs. This results in increased pulmonary pressures and deteriorating respiratory status. More and more blood is shunted through the alveoli. However, the blood is not adequately oxygenated and hypoxemia worsens. This can result in cerebral injury, edema, and brain death. Aggressive resuscitative efforts such as airway and ventilatory management, especially in the pre-hospital phase, improve survival of drowning victims. So pulmonary, we are going to assess ineffective breathing, dyspnea, respiratory distress, respiratory arrest, crackles, rhonchi, cough with pink frothy sputum, cyanosis. Cardiac, you can expect to see tachycardia, bradycardia, dysrhythmias, hypotension, and cardiac arrest. And other symptoms include panic, exhaustion, coma. We want to also investigate, do they have coexisting illnesses such as an MI or an injury, cervical spinal injury, core temperature slightly elevated or below normal, depends on the water temperature and the length of submersion. And compromised pulmonary and cardiac function can be noted on table 6810. Hello. Treatment of submersion injuries focuses on correcting hypoxia and fluid imbalances, supporting basic physiologic functions, and rewarming when hypothermia is present. Initial evaluation involves assessment of the airway, cervical spine, breathing, and circulation. We want to correct their hypoxia, correct their acid base and fluid imbalances, support their basic physiologic functions, and rewarm if hypothermia is present. All very important concepts to remember. Mechanical ventilation with positive end expiratory pressure, or PEEP, or continuous positive airway pressure, CPAP, are used to improve gas exchange across the alveolar capillary membrane when significant pulmonary edema is present. Ventilation and oxygenation are the primary techniques for treating respiratory failure. We may give mannitol or Lasix to treat cerebral edema or decrease free water. Deterioration in neurologic status suggests cerebral edema, worsening hypoxia, or profound acidosis. Drowning victims may also have head and neck injuries that cause the prolonged alterations in level of consciousness, and complications can develop in patients who are essentially free of symptoms immediately after the drowning episode. Consequently, we need to observe all victims of drowning in a hospital for a minimum of 23 hours. Additional observation is needed for patients who have comorbidities, such as heart disease. Patient teaching focuses on water safety, how to reduce the risk for drowning. We need to remind patients and caregivers to lock all swimming pool gates, use life jackets for all watercrafts, including inner tubes and rafts, and learn water survival skills, such as swimming lessons. We also need to emphasize the dangers of combining alcohol and drugs. And we need to manage and maintain ABCs, stabilize cervical spine, IV access for fluid resuscitation, 12 lead EKG, cervical spine and chest x-rays, and assess for other injuries. We want to assess hypothermia and possibly need to insert a gastric tube or urinary catheter. Now we're going to move on to stings and bites. Animals, spiders, snakes, and insects cause injury and even death by biting or stinging. Morbidity is a result of either direct tissue damage or lethal toxins. Direct tissue damage is a product of the animal size, characteristics of the animal's teeth, and the strength of the jaw. Tissue is lacerated, crushed, or chewed, while teeth, fangs, stingers, spines, or tentacles release toxins that have local or systemic effects. Death associated with animal bites is due to blood loss, allergic reactions, or lethal toxins. And injuries caused by select insects, ticks, or animals such as dogs and cats and humans are going to be described next. Bees, yellow jackets, hornets, wasps, and fire ants are all in the same family. Their stings can cause mild discomfort or life-threatening anaphylaxis. The venom can be cytotoxic, hemolytic, allergenic, or vasoactive. Symptoms may begin immediately or delayed up to 48 hours, and reactions are most severe with multiple stings. Most hymenopterans sting repeatedly. The domestic honeybee stings only once, usually leaving a barbed stinger with an attached venom sac in the skin so that release of venom continues. African honeybees, or killer bees, which look like domestic bees, have migrated into North America. If threatened, these bees aggressively swarm and can repeatedly sting their victims, such as humans and animals, and their attacks can be fatal. So what are we going to do? We want to remove the stinger using a scraping motion with a fingernail, knife, or needle. Or a credit card. Avoid using tweezers because they may squeeze the stinger and release more venom. We want to remove rings, watches, or any restrictive clothing around the sting site. Manifestations vary from stinging, burning, swelling, and itching to edema. They can also have headaches, fever, syncope, malaise, nausea, vomiting, wheezing, bronchospasm, laryngeal edema, and hypotension. Treatment depends on the severity of the reaction. We want to treat mild reactions with elevation, cool compresses, antipyretic lotions, and oral antihistamines. More severe reactions require IM or IV antihistamines, such as Benadryl or sub-Q epinephrine or an EpiPen, and corticosteroids, such as Decadron. Tick bites are most commonly found in the northwestern regions, Rocky Mountains, northeastern regions, but they can be found anywhere in the U.S. Conditions associated with tick bites include Lyme disease, Rocky Mountain spotted fever, and tick paralysis. The infected tick or the release of neurotoxin causes the disease. Infected ticks can bite and pass tick-borne pathogens to humans, causing illness such as Lyme disease, Rocky Mountain and spotted fever, tick paralysis, and southern tick-associated rash illness, tick-borne relapsing fever, and tularemia. So it just depends on the tick what disease that they transmit. So this is the way that we would normally remove a tick. This is from figure 68.5 from your textbook. We want to use tweezers to grasp the tick close to the skin. With a steady motion, pull the tick's body up and away from the skin. Don't be alarmed if the tick's mouth parts stay in the skin. Once the mouth parts are removed from the rest of the tick, it can no longer transmit disease. Ticks release neurotoxic venom as long as the tick head attaches to the body. Therefore, safe removal of the tick is essential for effective treatment. Again, we can use forceps or tweezers. We don't want to use a hot match, petroleum jelly, nail polish, or other products to remove the tick, since these measures may cause the tick to salivate, thus increasing the risk of infection. Lyme disease is the most common tick-borne disease in the U.S. Symptoms appear within days of the bite from the hard tick that has been attached for at least 48 hours. The first stage of this disease begins with flu-like symptoms, headache, stiff neck, and fatigue. And some patients may develop a characteristic bullseye rash, a circular area of redness 5 centimeters or more in diameter. The rash, if it develops, will disappear even if the patient is not treated. We're going to treat the spirochete with either amoxicillin or cefuroxime. And after initial manifestations, they can have monoarticular arthritis, meningitis, and neuropathies occur days or weeks after. We want to treat with penicillin or ceftriaxone. The later stages, they can develop chronic arthritis, peripheral nerve problems, and heart disease, which lasts several months to years. And we can see more of this under the Lyme disease in chapter 64 in the textbook. Rocky Mountain spotted fever is caused by the rickettsia, a bacterium that is spread to humans by the Loxod tick. It has an incubation period of 2 to 14 days. A pink macular rash appears on the palms, wrists, soles, feet, or ankles within 10 days of exposure. Other symptoms include fever, chills, malaise, malaises, and headache. Diagnosis is often difficult in the early stages, and without treatment, the disease may be fatal. Antibiotic therapy with doxycycline is a treatment of choice. For tick paralysis, this is caused by a neurotoxin from a wood tick or a dog tick. It occurs 5 to 7 days after the exposure. They can have flaccid, ascending paralysis that will develop over 1 to 2 days. Fatal condition if the tick is not removed, and return of muscle movement usually occurs within 48 to 72 hours after removing the tick. Human bites also cause puncture wounds or lacerations. These carry a high risk of infection from oral bacterial flora, most commonly Streptococcus aureus, and Streptococcus organisms and hepatitis virus. Infection rates are as high as 50% when victims do not seek medical care within 24 hours of injury. An example of a human bite. Hands, fingers, ears, nose, vagina, and penis are the most common sites of human bites and are frequently a result of violence or sexual activity. Patients with Botch's fracture, which is a fracture of the 4th or 5th metacarpal, often have concurrent open wounds on the knuckles from the striking the teeth. The human jaw has great crushing ability, causing laceration, puncture, crush injuries, soft tissue tearing, and even amputation. There's a high risk of infection, as high as 50% if no medical care occurs within 24 hours. People who are at high risk for infection are infants, older adults, immunocompromised patients, and substance or alcohol use disorder. Also, people who have diabetes and those taking corticosteroids because they're immunocompromised. People at greatest risk of infection, again, are the infants, older adults, immunocompromised patients, alcoholics, diabetics, and people taking corticosteroids. We need to initially clean with copious irrigation, debridement, tetanus prophylaxis, and analgesics. Prophylactic antibiotics for bite at risk for infection, such as wounds over joints, wounds that are more than 6 to 12 hours old, puncture wounds, bites on the hand or the foot. So we're going to leave puncture wounds open. We're going to splint wounds over joints. Lacerations are loosely sutured. However, initial closure is used for facial wounds. The patient is admitted for IV antibiotic therapy when an infection is present, and those patients have an increased incidence of cellulitis, osteomyelitis, and septic arthritis. We also need to report animal and human bites to the police as required by the area, and you will know those if you are working in emergency department, which counties require reports and what is done with the patients. We need to consider rabies, post-exposure prophylaxis in the management of all animal bites. Rabies are generally transmitted via saliva from the bite of the infected animal. It can also be spread by scratches and by contact with infected secretions through mucous membranes. Any warm-blooded mammal, dogs, raccoons, bats, can carry rabies. We want to consider rabies exposure if an animal attack was not provoked, involves a wild animal, or involves a domestic animal not immunized against rabies. Always provide rabies post-exposure prophylaxis when the animal is not found or a wild animal causes the bite. A neurotoxic virus found in the saliva of the infected animals causes rabies. The virus spreads through the CNS via the peripheral nerves, and after a minimum 2-week incubation period, patients experience flu-like symptoms, pain, paresthesias, or numbness. Rabies prophylaxis may be started before symptoms occur. Otherwise, the disease will progress, showing agitation, hypersalivation, dysarthria, hallucinations, nuchal rigidity, seizures, and coma, and it is fatal. Death results from respiratory and cardiovascular collapse within a few days after the onset of coma. We want to start the regimen with an initial weight-based dosage of rabies immune globulin, or RIG, to provide passive immunity. We're going to follow this with a series of 4 injections of human diploid cell vaccine, or HDCV, on days 0, 3, 7, and 14 to provide active immunity. Since rabies is nearly always fatal, management efforts are directed at preventing the transmission and onset of the disease. Although death from rabies is significant worldwide, only 1 to 3 people die annually in the U.S. Rabies vaccine is encouraged for patients or people who travel globally, since it does remain a serious world health concern. If possible, we're going to give the calculated dose of RIG via infiltration around the wound edges. We want to give any remaining volume of RIG-IM at a site distant from the vaccine site, for example, the gluteal site for bite wounds in the arm, and give the HDCV-IM in the deltoid. Now we're going to move on to poisonings. A poison is any chemical that harms the body. More than 5 million cases of human poisonings occur each year in the U.S. Poisonings can be accidental, occupational, recreational, or intentional. Natural or manufactured toxins can be ingested, inhaled, ingested, splashed in the eye, or absorbed through the skin. Table 6811 will present common poisons. Severity of the poisoning depends on the type, the concentration, and the route of exposure. Toxins can affect every tissue in the body, so symptoms can be seen in any body system. Specific management of toxins involves decreasing absorption, enhancing elimination, and implementing toxin-specific interventions. Again, specific management of toxins involves decreasing absorption, enhancing elimination, and implementing toxin-specific interventions. We need to consult the local poison control center 24 hours a day for the most current treatment protocols for specific poisons. Decontamination takes priority over all interventions except life support measures. We need to wear PPE to prevent secondary exposure, and anytime you're decontaminating, you will be fully protected. Hazardous materials specialists may treat pre-hospital and repeat at the hospital. The most common and effective intervention for management of poisonings is administration of activated charcoal orally or via a gastric tube within 1 hour of poison ingestion. Many toxins adhere to charcoal and pass through the GI tract rather than absorbed into the circulation. Activated charcoal does not absorb ethanol because it's absorbed into the bloodstream, hydrocarbons, alkali, iron, boric acid, lithium, methanol, or cyanide. Adults receive 50 to 100 grams of charcoal, and for some toxins like phenobarb or DIG, multiple dose charcoal may be required. Although a lot of times with DIG, we're going to give Digibind. Contraindications to charcoal administration include diminished bowel sounds, paralytic ileus, and ingestion of a substance poorly absorbed by charcoal. Charcoal can absorb and neutralize antidotes. So if you give Mucomist for Tylenol or acetaminophen toxicity, it's going to not make it effective. You never want to give these immediately before, with, or shortly after charcoal. Skin and ocular decontamination involves removal of toxins from skin and eyes using copious amounts of water or saline. Most toxins, with the exception of mustard gas, may be safely removed with water or saline. Water mixes with mustard gas and releases chlorine gas. As a rule, brush dry substances off the skin and clothing before using water. And do not ever, this is my mom's voice, ever, you remove powdered lime with water, because you're going to make a very strong acid. It should be brushed off always, and you will be wearing PPE if you have somebody that is contaminated. So you're going to wear personal protective equipment, such as gloves, gowns, goggles, respirators, for decontamination to prevent secondary exposure. Decontamination procedures are usually done by those specifically trained in hazardous material decontamination before the patient arrives at the hospital, and again at the hospital if necessary. Decontamination takes priority over all interventions except those needed for basic life support. Giving cathartics, whole bowel irrigation, hemodialysis, urine alkalinization, chelating agents, and antidotes increases the elimination of poisons. Cathartics, such as sorbitol, are given together with the first dose of activated charcoal to stimulate intestinal motility and increase elimination. We want to avoid multiple doses of cathartics because of potentially fatal electrolyte abnormalities. Whole bowel irrigation is controversial but can be effective for swallowed objects such as cocaine-filled balloons or condoms, and heavy metals such as lead and mercury. There is a high risk of electrolyte imbalance caused by fluid and electrolyte losses with this approach. Hemodialysis is reserved for patients who develop severe acidosis from ingestion of toxic substances such as aspirin. Other interventions include alkalinization and chelation therapy. Sodium bicarb administration raises pH more than 7.5, which is particularly effective for phenobarb and salicylate poisoning. Vitamin C is added to the IV fluids to enhance excretion of amphetamines and quinidine, and chelation therapy is considered for heavy metal poisonings, such as edetate calcium disodium for lead poisoning. A limited number of true antidotes are available, and many of these agents are themselves toxic. We want to focus patient teaching for toxic emergencies on how the poisoning occurred. Arrange for an evaluation and follow-up by a mental health professional for all patients who experience poisoning because of a suicide attempt or substance abuse. Many healthcare workers, such as nurses, housekeeping, are at risk for exposure to hazardous materials, such as antineoplastic drugs and cleaning agents. We always consult the Material Safety Data Sheet, or MSDS, required by OSHA for specific information regarding hazardous agents in the workplace. OSHA should evaluate all poisoning related to a workplace hazard. Terrorism. The threat of terrorism is an ongoing concern. It involves overt actions such as dispensing of nuclear, biologic, or chemical agents as weapons for the express purpose of causing harm. Prompt recognition and identification of potential health hazards are essential in the preparedness of healthcare professionals. Prompt recognition and identification of potential health hazards are essential. Biologic agents most commonly used in terrorist attacks include anthrax, smallpox, botulism, plague, tularemia, and hemorrhagic fever. Anthrax, plague, and tularemia are treated effectively with antibiotics if sufficient supplies are available and the organisms are not resistant. Smallpox can be prevented or the incidence reduced by vaccination, even when given after exposure. Botulism is treated with antitoxin, and several other vaccines are being studied. Vaccines for some hemorrhagic fevers, like yellow fever, Argentine hemorrhagic fever, exist, and others are being investigated, such as for Ebola. Chemicals are also used as agents of terrorism and are categorized according to their target organ or effect. For example, sarin is a highly toxic nerve gas that can cause death within minutes of exposure. It enters the body through the eyes and skin and acts by paralyzing the respiratory muscles. Antidotes for nerve agent poisoning include atropine or atropine and prolidoxime chloride or 2-PAM chloride. Multiple doses may be needed to reverse the effects of the nerve agents. Phosgene is a colorless gas normally used in chemical manufacturing. If you inhale it at high concentrations for a long enough period, it causes severe respiratory distress and pulmonary edema and death. Mustard gas is yellow to brown and has a garlic-like odor. The gas irritates the eyes and causes skin burns and blisters. Protocols to treat victims of chemical exposure vary and relate to the specific agent. Radiologic or nuclear agents represent another category of agents of terrorism. Radiologic dispersal devices, or RDDs, also known as dirty bombs, consist of a mix of explosives and radioactive materials. When the device is detonated, the blast scatters radioactive dust, smoke, and other materials into the surrounding environment, resulting in radioactive contamination. The main danger from an RDD results from the explosion, which can cause serious injuries to the victims. The radioactive materials used in an RDD, such as uranium or iodine-131, do not usually generate enough radiation to cause immediate serious illness, except in those victims who are in close proximity to the explosion. However, the radioactive dust and smoke can spread and cause illness if it's inhaled. Since radiation cannot be seen, smelled, felt, or tasted, you should start measures to limit contamination, like covering the patient's nose and mouth, and provide for decontamination, such as a shower. Ionizing radiation, such as that from a nuclear bomb or damage to a nuclear reactor, represents a serious threat to the safety of victims and the environment. Exposure to ionizing radiation may or may not include skin contamination with radioactive material. We need to initiate decontamination procedures immediately if external radioactive contaminants are present. Acute radiation syndrome develops after a substantial exposure to ionizing radiation and follows a predictable pattern. And you can have additional information on ARS if you go to the website www.bt.cdu.gov/radiation/ARS physician facts sheet.asp. Explosive devices such as TNT or dynamite that are used as agents of terrorism result in one or more of the following types of injuries: blast, crush, or penetrating. Blast injuries result from supersonic overpressurization shock wave caused by the explosion. This shock wave primarily damages the lungs, the GI tract, and the middle ear. Crush injuries, for example, blunt trauma, often result from explosions in confined spaces causing structural collapse, like falling debris. Some explosive devices contain materials that are projected during the explosion, such as shrapnel, leading to penetrating injuries as well. The term emergency usually refers to an extraordinary event, a multi-vehicle crash that requires a rapid and skilled response and that the community's existing resources can manage. An emergency is differentiated from a mass casualty incident, MCI, in that an MCI is a man-made involving agents or natural, which would be like a hurricane. It's an event or disaster that overwhelms the community's ability to respond with existing resources. MCIs usually involve a large number of victims, physical and emotional suffering, and permanent changes within a community. MCIs always require assistance from people and resources outside the affected community, such as the American Red Cross, the Federal Emergency Management Agency, or FEMA. When an emergency or an MCI occurs, first responders, such as police, emergency medical personnel, are sent to the scene. Triage of victims of an emergency or an MCI differs from the usual triage that occurs in an ED. In an ED, we take longer time, but triage of casualties differs because it has to be done in less than 15 seconds when it's out in the field. So you only have 15 seconds to determine if they're going to live or die. We use a system of colored tags that designate both seriousness of injury and likelihood of survival. Triage of victims of an emergency or MCI must be rapid, again, less than 15 seconds. In general, 2/3 of victims will be tagged yellow, the remaining are tagged red, blue, or black. So green is a minor injury, we call them the walking wounded. Yellow is non-life-threatening tag, which indicates non-life-threatening injury, but we have to be careful because they can easily go to a red. Red indicates life-threatening injury. Blue indicates those who are expected to die, and black identifies the dead. Victims need to be treated and stabilized, and if there's a known or suspected contamination, decontaminated at the scene. After this, they are moved to the hospitals. Many other victims arrive at hospitals on their own. They're walking wounded. The total number of victims a hospital can expect is estimated by doubling the number of victims who arrive in the first hour. Generally, 30% of the victims require admission to the hospital, and half of these need surgery within 8 hours. In addition to the services provided by first responders, many communities have developed community emergency response teams, or CERTs. CERTs are recognized by FEMA as important partners in the emergency preparedness. The CERT training helps citizens understand their personal responsibility in preparing for a natural or man-made disaster. Participants are taught what to expect after disaster and how to safely help themselves, their family, and their neighbors. Training includes life-saving skills with emphasis on decision-making and rescuer safety. CERTs are an extension of the first responder services. They can offer immediate help to victims and organize untrained volunteers to assist until professional services arrive. All healthcare providers have a role in emergency and MCI preparedness. Knowledge of the hospital's emergency response plan is essential. This includes individual roles and responsibilities of the members of the response team, plus participation in the emergency. MCI preparedness drills on a regular basis so that they are prepared. Several types of drills can assess a hospital's level of emergency preparedness. These include hospital disaster drills, computer simulations, and tabletop exercises. Response to MCIs often requires the aid of federal agency. The National Incident Management System, or NIMS, is a section within the U.S. Department of Homeland Security. NIMS is responsible for coordinating federal, state, and local government efforts to respond to and manage domestic MCIs. One important aspect of NIMS is the development of the Incident Command System. This standardized organizational structure provides for the management of all incidents. NIMS requires that all emergency services and related disciplines such as hospitals, healthcare providers, emergency response services wishing to participate in the emergency management of disasters must be NIMS and ICS trained. And you can take these courses online at no cost if you want to. The National Disaster Medical System, or NDMS, is a part of the U.S. Department of Health and Human Services, Office of Preparedness and Response. The NDMS expands the nation's medical response capability by organizing and training volunteer disaster medical assistant teams, or DMATs. Each DMAT consists of members with a variety of health or medical skills and those with specialized support skills, such as communications, logistics, security. DMATs are sent to disaster sites with enough supplies and equipment to remain self-sufficient for 72 hours while providing medical care. DMAT personnel are deployed for a period of 2 weeks. All disasters result in psychological stress to the individuals involved. This stress can persist for an extended period and is influenced in part by the nature of the event, the individual's age, pre-existing coping mechanisms, role in the event, and medical and psychological history. Many hospitals and DMATs have a critical incident stress management unit. This unit arranges group discussions to allow participants to share and validate their feelings and emotions about the experience. This is important for emotional security or recovery. One thing that you need to be knowledgeable about also is our pod system. St. Francis is a pod in each state is divided into pods, and basically what they will do is provide resources, knowledge, trainings to any of the hospitals or rescue centers in their pod. So we would provide the resources so that they can survive, such as when we had the tornado in Washington or when we have floods. We can actually have teams that can respond to these incidences. In Peoria, we have the REMERT team, which is a regional emergency medical team. And we have several trainings throughout the year, as well as certifications that we have to also be recertified on an annual basis. So they are responsible for education, but also providing the resources and getting out to the areas should they need help. But also, again, to let the first responders be responsible to starting the event so that our patients can have the best cares. Question. While performing triage in the ED, you determine which patient should be seen first. Patient with burns on the face and chest, blood pressure 120/80, heart rate 92, respirators 24. Patient with a deformed leg indicating a fractured tibia, blood pressure 110/60, heart rate 86, respirators 18. Patient with type 1 diabetes and ketoacidosis, blood pressure 110/60, heart rate 100, respirators 32. Patient with respiratory infection and a cough, productive of greenish phlegm or sputum, blood pressure 128/86, heart rate 88, respirators 26. So the answer is C. A triage system identifies and categorizes patients so that the most critical are treated first. The ESI is a 5-level triage system that incorporates concepts of illness severity and resource utilization to determine who should be treated first. And initially, the nurse will assess the patient for any threats to life or presence of high-risk situation. The patient with diabetic ketoacidosis, in this case, is the most critical. Assessment of a male patient during the primary survey indicates delayed cap refill of the extremities. He can't explain the events before admission to the ED. Which action should you take immediately? Apply leads, insert 1 or 2 large IVs, continue the primary survey, or initiate pulse ox by placing the monitoring device on the patient's index finger. The answer is D. The primary survey focuses on airway, breathing, circulation, disability, and exposure environmental control. It serves to identify life-threatening conditions so that appropriate interventions can be initiated. The nurse may identify life-threatening conditions related to airway, breathing, and circulation, and disability at any point during the primary survey. When this occurs, the nurse should start interventions immediately and before moving to the next step of the survey. The patient has decreased oxygenation, and further assessment with pulse ox is indicated. Several patients are admitted to the ED after exposure to an aerosolized agent that is believed to be hemorrhagic fever virus, such used as a bioterrorism agent. Which statement by the nurse is most accurate? Treatment for this viral disease is mostly supportive. Cipro is the best treatment for this disease. This disease cannot be spread by contact with body fluids. A vaccine is available to prevent transmission of this disease. The answer is A. Only supportive treatment is available for hemorrhagic fever. A vaccine is available for yellow fever only. The disease is carried by rodents and other mosquitoes and through direct person-to-person contact with body fluids. The virus can be aerosolized. Cipro is used to treat a bacterial infection. Any questions?